Welcome to IM Updates. This is Yan. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from June the 19th to June 26th. Here's the overview. On June 23rd, the European Hematology Association published clinical practice guidelines for diagnosis, treatment, and follow-up of Hodgkin lymphoma. The 2026 guideline represents a significant evolution from previous versions. Key changes reflect the results of major phase 3 trials. First, new standard of care for advanced classic Hodgkin lymphoma. The most impactful change is the adoption of BRECADD as the preferred treatment for younger patients with advanced disease. This replaces the previous standard EBEACOPP due to BRECADD's superior progression-free survival, which is 93.6% versus 90.6% at 5 years, and lower rates of severe toxicities like hematologic issues, neuropathy, and infertility. Second, a new alternative for advanced classic Hodgkin lymphoma. The PD-1 inhibitor-containing regimen NAVD is now formally recognized as a less intensive but highly effective alternative to BRECADD, supported by the SWOG as 1826 trial. Third, refined path-guided strategy for early unfavorable disease. The guideline now firmly supports omitting radiotherapy in patients with early-stage unfavorable disease who achieve a negative PET scan after 2+2 chemotherapy, a strategy validated by the HD17 study. Fourth, new standard for older patients. For the first time, a targeted regimen, NAVD, is recommended as the preferred option for older, fit patients, a group historically difficult to treat with standard chemotherapy. Fifth, PD-1 inhibitors in relapsed disease. The role of PD-1 inhibitors has been moved earlier in the treatment pathway, now being a standard component of salvage therapy before stem cell transplantation, rather than being reserved for later lines. On June 23rd, the 2026 GINA Severe Asthma Guide was published. The 2026 update introduces several new elements that expand treatment options and refine the decision-making process. The guide includes two newly approved biologic options: Depemokimab, a new long-acting anti-IL-5 biologic administered every 26 weeks for patients aged over 12 years with severe eosinophilic asthma; Omalizumab, IgE, the first biosimilar to omalizumab anti-IgE, offering a provide clearer guidance on choosing between available biologics. It now emphasizes consideration of predictors of response like eosinophils and pheno comorbidities, especially type 2 reactions, for example, nasal polyps, atopic dermatitis, and practical factors, including cost, dosing frequency, and route of administration. The guide also adds a new table that lists other approved indications for these biologics, helping clinicians understand the full therapeutic potential for patients with multiple type 2 conditions. On June 24th, World Association for Bronchology and Interventional Pulmonology and American Association for Bronchology and Interventional Pulmonology published a consensus statement evaluates the therapeutic role of medical thoracoscopy in benign pleural disease. Key recommendations include: for recurrent benign pleural effusions, either MT with talc poudrage or talc slurry by chest tube may be used for pleurodesis. For primary spontaneous pneumothorax, VATS is recommended over MT for recurrence prevention. For secondary spontaneous pneumothorax, talc slurry via chest tube preferred over MT. For empyema, intrapleural enzyme therapy with TPA plus TNase preferred over MT as first salvage to avoid surgery. If surgical intervention is indicated, VATS is preferred over MT. For tuberculosis plurifusion, MT over fat for biopsy because of less invasive and shorter hospital stay. Other considerations include high complication or recurrence rates in hepatic hydrothorax, where multidisciplinary decision-making is essential. Non-specific pleuritis needs follow-up over 1 year, since around 8% risk of missed malignancy, especially mesothelioma. For connective tissue diseases, treat with immunosuppressants alongside diuretics. Pleurodesis can be considered if recurrent despite medical management. For TOG, use grated TOG to minimize inflammatory reactions, which can cause dense adhesions, complicating future surgery. And smoking cessation is a critical component of pneumothorax management. On to FDA news. On June 24th, the FDA approved palbociclib, brand name is Ibrance, in combination with trastuzumab with or without pertuzumab and endocrine therapy for the maintenance treatment for adults with HR positive, HER2 positive, locally advanced or metastatic breast cancer following induction treatment. The major efficacy outcome measure was investigator-assessed progression-free survival per RECIST version 1.1. Overall survival was an additional efficacy outcome measure. A statistically significant improvement in investigator-assessed PFS was observed for palbociclib with trastuzumab with or without pertuzumab and endocrine therapy compared to trastuzumab with or without pertuzumab and endocrine therapy alone. Hazard ratio is 0.76. Median PFS could not be adequately described because of censoring. At the time of the PFS analysis, OS data were not mature. The palbociclib prescribing information includes warnings and precautions for neutropenia, interstitial lung disease or pneumonitis, and embryo-fetal toxicity. On June 24th, the FDA approved sacituzumab govitecan, HZIY, the brand name is Trodelvy, for 2 indications in patients with triple-negative breast cancer, or TNBC. The first indication supported by Ascent 03 is for sacituzumab govitecan, HZIY, as a single agent for the first-time treatment. For the first-line treatment of adults with unresectable, locally advanced, or metastatic TNBC who are not candidates for PD-1 or PD-L1 inhibitor-based therapy. The second indication supported by Ascent 04 or Keynote D19 is for sacituzumab govitecan, HZIY, in combination with Keytruda or Keytruda QLEX for the first-line treatment for adults with unresectable, locally advanced, or metastatic TNBC whose tumor express PD-L1 CPS over 10 as determined by an FDA-authorized test. The primary efficacy of Trodelvy as a single agent for TNBC outcome measure was progression-free survival, PFS, as assessed by blinded independent central review, per RECIST version 1.1. Additional efficacy outcome measures included overall survival and confirmed objective response rate. Median PFS was 9.7 months in the Trodelvy arm and 6.9 months in the TPC arm. Confirmed ORR was 50% and 47% in the respective arms. OS data were immature. Primary efficacy of Trodelvy in combination with Keytruda outcome measures was PFS by blinded independent central review per RECIST version 1.1. Median PFS was 11.2 months in the Trodelvy arm and 7.8 months in the TPC plus Keytruda arm. Hazard ratio is 0.65. Confirmed ORR was 61% and 55% in the respective arms. OS data were immature. The prescribing information of Trodelvy contains a boxed warning for diarrhea and neutropenia and includes warnings and precautions for hypersensitivity and infusion-related reactions, nausea, vomiting, patients with reduced GT1A1 activity, and embryo-fetal toxicity. On June 24, the FDA has approved Tryngolza, or olezarsen used with diet to reduce triglycerides and the risk of acute pancreatitis in adults with severe hypertriglyceridemia. The efficacy and safety of Tryngolza were demonstrated in 2 randomized double-blinded placebo-controlled trials in a total of 1,061 adults with severe hypertriglyceridemia. In the first trial, the average percent change in triglycerides from baseline to month 6 in the Tryngolza treatment group was minus 63% for the 50 mg dose and minus 72% for the 80 mg dose compared to the placebo group. In the second trial, the average percent change in triglycerides from baseline to month 6 in the Tryngolza treatment group was minus 49% for the 50 mg dose and minus 55% for the 80 mg dose, compared to the placebo group. In the integrated analysis of the 2 trials, the rate of acute pancreatitis was reduced in the pooled Tryngolza group compared with placebo. The most common adverse reactions in patients treated with Tryngolza for severe hypertriglyceridemia are injection site reactions and liver enzyme increases. Healthcare providers should consider liver enzyme testing before Tryngolza initiation or an increase in dose and when indicated thereafter. If elevations in liver enzymes persist, healthcare providers may consider dose interruption and/or dose reduction. That's all for today. Enjoy your weekend and see you next week.